going to discuss a case from the point of cardiology as regards the cardiorenal syndrome. As we all know, the cardiorenal syndrome is defined as a pathophysiological disorder of the heart and kidneys whereby acute and chronic dysfunction in an organ may induce acute or chronic dysfunction in the other organ. The prevalence of moderate to severe kidney impairment, GFR less than 60, is 36% in patients with heart failure. It's not uncommon to see renal impairment in patients with heart failure, and the mortality is increased 15% for every 10 milliliter per minute reduction in the estimated GFR. Every 10 millimeter reduction in the GFR is translated to 15% more mortality in patients with heart failure and CKD. Renal dysfunction and cardiovascular outcome, when the search for the outcome of patients stratified by the GFR with low ejection fraction, less than 40%, the highest mortality was among patients with low GFR, and patients with ejection fraction more than 40, even if they have a GFR less than 40, when they are stratified by lower GFR, there is higher mortality. The outcome of heart failure with 1 year death is much more increased with worsening of renal function. Patients with heart failure, when there is worsening of renal function, there is much mortality, such as our patients. This patient, he has acute heart failure, deterioration in both. He has a CKD first 1.6, he's a CKD patient, and he has a mid-range ejection fraction of 40%, and then there is severe deterioration of the ejection fraction with the development of atrial fibrillation. His ejection fraction dropped to 20%, as his renal function, the serum creatinine level was elevated up to 5.2 milligram per deciliter. So there is deterioration in both renal function and cardiac function. And the cardiovascular disease remains the major cause of mortality and morbidity in patients with advanced renal disease. In the general population, the incidence of coronary heart disease is between 5 to 12%, with an annual mortality of 0.28%. In patients with dialysis, 40% the presence of coronary heart disease is 40%, and we have annual mortality in these patients with dialysis and coronary heart disease is up to 9%. And there is an interplay between the presence of CKD, heart failure, and acute coronary syndrome. If we have a patient with heart failure and CKD, he is more likely to develop an acute coronary syndrome. If these unlucky patients develop acute coronary syndrome, there is much deterioration in his function. Patients with heart failure who are at increased risk of development of cardiorenal syndrome are patients with hypertension, diabetes, severe vascular disease, and elderly. And in our patient, I think we have his blood pressure is controlled. He's diabetic patients. He has a previous cerebrovascular stroke, and his age, I don't think, was about the 50s. So he has two of these criteria. And the cardiovascular risk in CKD, there are multiple mechanisms of increased risk: presence of inflammation, oxidative stress, inducible dysfunction, protein energy losing, sympathetic activation, prothrombotic milieu, vascular calcification, classical uremic toxin, subclinical hypothyroidism, release of adipokines, and anemia, as in our patients. All these factors contribute to higher risk in patients with patients with cardiovascular and renal disease. Types of cardiorenal syndrome: we have 5 types of cardiorenal syndrome. Type 1 is an acute cardiorenal syndrome in which there is acute worsening of heart failure leading to kidney injury and/or dysfunction. So we have deterioration of and worsening of acute heart failure resulting in leading to kidney injury and dysfunction. Type 2, chronic cardiorenal, it's in which there is chronic abnormality in the heart function leading to kidney injury and dysfunction. So the first, type 1, heart failure resulting in kidney injury. Type 2, chronic heart failure resulting in kidney injury. Type 3, it's acute worsening of renal function leading to heart injury or dysfunction. So we have an acute renal failure resulting in heart injury. Type 4, we have chronic kidney disease resulting in cardiac injury and dysfunction. So chronic kidney disease, which results in heart failure. And type 5, there is a systemic condition leading to simultaneous injury and/or dysfunction in the heart and the kidney. In our patients, there is much overlap between these types in our patients, because at the beginning he's a chronic kidney disease patient. He has a CKD of creatinine level was 1.6. He's a heart failure patient with mid-range ejection fraction. Ejection fraction was 40%, and the patient developed acute heart failure which resulted in acute deterioration of renal function. So the most appropriate will be it's an interplay between type 1 and 2. It's an overlap between type 1 and type 2 because we have chronic heart failure with deterioration and CKD with deterioration. So there is an overlap between both syndromes in our particular patient. So that's why I think that there is an overlap in your response to the question. The pathophysiology of cardiorenal syndrome, the mechanism underlying the interplay between heart failure and renal dysfunction is still not completely understood. There is decline in cardiac function resulting in decrease in tissue perfusion, adversely affecting renal perfusion, is well known and provide an explanation for some aspects of the cardiorenal syndrome. If we have first the cardiorenal, we have the cardiac insult first with acute heart failure, with all the pathophysiological interplay of heart failure, acute heart failure mechanisms, and in case of renal cardiac disease, there is acute kidney injury and CKD, and release of multiple mediators, derangement of the renal angiotensin system, and all these results in a complicated puzzle in uremic patients with cardiovascular disease. You have the traditional risk factors which are present, you have an inflammatory markers which are much more exaggerated, you have exaggerated endothelial dysfunction, you have a vascular calcification, and every patient, when we are doing coronary angio for a patient with renal disease, you can see the coronaries without even injecting contrast because of the severe calcification in the coronaries. We have surrogate oxidative markers, release of adipokines, and other unknown risk factors which may interplay between the presence of the complicated pathophysiological mechanism in patients with renal and coronary artery disease. The management of cardiorenal syndrome, we have goals. First, if we have a patient with acute heart failure, as in our patient, a patient with acute decompensated heart failure, our main goal is to remove the volume. The patient is oliguric, and we have to remove the volume and to optimize the hemodynamics. In order to reach this point, we are going to follow the European guidelines of acute and chronic heart failure. And in this, in patients with heart failure with acute decompensation, our main concern is first, if the patient blood pressure is maintained, blood pressure was 100/60, the main aim is to give diuretics. If the patient is tolerating diuretics well and good, we can give loop diuretics first. Then, if the patient is still anuric, we have to resort to the hemofiltration. As regards if the patient is still after passing the acute phase and our patient condition is stable, we can start for him beta blockers. When we are going to start the beta blockers, our patient must be in a dry and not in pulmonary, there is no pulmonary congestion. In this particular patient, to start angiotensin receptor blockers, either ACE inhibitor or ARBs, we cannot start in these patients because of his serum creatinine level was 5.2, and we don't know how is his serum potassium level. And in this particular patient, we cannot start both of them. As regards the presence of atrial fibrillation in our patients, we have to control his heart rate. The only drug which is approved in this particular patient will be amiodarone. We cannot give any other antiarrhythmic in this particular patient with heart failure. And if the heart rate is not controlled, the only thing we can do is heart rate reduction with a reduced dose of serum of the digoxin. And the last resort to control his heart rhythm is to do ablation in order to nodal ablation if we fail to control his heart rate in order to control the atrial fibrillation. If it is an acute atrial fibrillation, the story will be different a little bit because we can do transesophageal echo to exclude the presence of left atrial thrombi and then to do cardioversion. So these are the treatment in patients with symptomatic heart failure with reduced ejection fraction. As we said, for our patient, we can use diuretics. Angiotensin receptor neprilysin inhibitor, we cannot use it in this patient because of his serum creatinine level. ARBs and ACE inhibitor could not be used. Hydralazine and isorbidinitrate is a very good combination to reduce the preload in this particular patient with renal dysfunction. We can use a dose of 20 milligram of isorbidinitrate with 37.5 milligram of hydralazine 3 times per day in order to reduce the afterload. And in this there is fixed pill combination of dinitrates plus hydralazine, which is available abroad, not available in our country, and this fixed dose combination of these two drugs is very efficient. Hydralazine and isobutanol may be considered in self-identified black patients with ejection fraction less than 50%, combined with dilated LV with NEA class 3 to 4, despite of treatment with an ACE or a beta blocker and mineralocorticoid receptor antagonist to reduce the risk of hospitalization and death. Hydralazine and hydroxybutyrotrate can be combined in symptomatic heart failure patients who cannot tolerate ACE or an ARB, or they are contraindicated to reduce the risk of death. So they are very useful in this particular patient. As we said, digoxin with the reduced dose can be used, and the use of N3-PFA is a class 2B recommendation in patients with symptomatic heart failure. This is the management of patients with chronic type 2 cardiorenal syndrome. We are going to follow the guidelines of heart failure. I'm going to type 3 in renal cardiac disease. We have to treat this patient with a nephrologist. So I think in this complicated patients with advanced heart failure and CKD, our lines of treatment as regards the cardiology point of view will be first diuresis. If the blood pressure of the patient dropped, we have to use inotropes, and the inotropes available in Egypt will be only what we have is dopamine, dobutamine, and norepinephrine. If available, levosimendan as a positive as calcium and sensitizer is a very, very beneficial in this particular patient, not contraindicated. If the patient is still symptomatic, we can use a mechanical support device as an impeller or intra-aortic to bridge up to stabilization. As regards his renal function, what we can do, we cannot give, most of our medications are contraindicated. We have to control his heart rate, and cardiac resynchronization also in this particular patient, because there is a question, there is no role for cardiac resynchronization in this patient. He has AF and the narrow complex.